there's no fix for it because you've lost the antagonist on the other side. So you've lost foot stability, you've lost the ability to stabilize. So now without that tension there, all the pressure goes up like this. You're likely to end up with hammer toes, and then you get all this top of the foot pain. So like, we're not designed to just cut stuff, guys. Like, it's not good. We're designed to have agonist-antagonist relationships in our muscles. So you'll see almost the same thing too when you see people want to reattach the lateral epicondyle when somebody's got tennis elbow. I mean, it's a ludicrous thing to do because it doesn't have the same lever attachment point anymore, right? We changed the lever. So it doesn't function the same, and so its antagonist also doesn't function the same. So not only is it unpredictable, but it's almost certainly not going to function properly and almost certainly going to cause pain. That's not the way we're designed. So yeah, after all your rounds of steroid shots and shockwave therapy, that's usually what they go to, and they cut the plantar fascia, and people are usually never the same again. Because now you can't generate any force with your foot also, right? So you can imagine the amount of tension that goes to the Achilles tendon and the calf as well. So now you're exponentially more likely to have Achilles tendonitis as a result of that. Because if both of those tendons are supposed to be pulling on the bone equally, but now you don't have any tension on one side, this other one is going to cause an upward drift in the calcaneus, which is going to damage the subtalar joint, cause Achilles tendinopathy, and a whole sort of other issues. And when you mess with the feet, you mess with the knees, you mess with the hips, you mess with the pelvis. So it's not a good look. But people get desperate, and that's the only option that's given to them sometimes. All right, so ankle and foot. So we talk about the bones of the ankle and the foot. So the lateral malleolus is part of the fibula, okay? Medial malleolus is part of the tibia. So we also have the talus, the calcaneus, the navicular, the cuboid, 3 cuneiforms, 5 metatarsals, and 5 phalanges. So you can see the breakdown of these, the far away ones, the green ones are the phalanges. Then you have the metatarsals, the cuneiforms, and the navicular. So we have our middle phalanges, distal phalanges, and proximal phalanges. Metatarsals, cuneiforms, okay? So we only have 3 of those. So the cuboid basically attaches as 2 articulations to the last 2 toes. The first 3 toes all have their own articulations with cuneiforms. So cuneiform there, cuneiform there, cuneiform there. Here's our cuboid, which attaches to the 4th and 5th digits, right? Here's our navicular. So the navicular, you can feel that sticking out on the inside of the foot. Here's the talus, the calcaneus, or the heel bone, and you have the transverse tarsal joint, which can also get jammed on people. All these joints are held together with ligaments, so we should have some level of stability there as well. So looking at the joints of the ankle, we have the syndesmosis between the tibia and the fibula. So syndesmosis is a connective tissue. It helps to hold those areas together. When they get torn, there can be shearing between them, and when there's actual shin splints, a lot of times there's irritation or even partial tearing there. So the talocrural joint, or the true ankle joint, or the tibiotalar joint. So if we want to be very technical, right, we want to use tibiotalar. So it describes the 2 bones that are articulated by that joint. Talocrural is, it's not very helpful because you're like, what's the crural bone? Well, as anatomy students, you need to be able to understand what we're talking about. So in my opinion, you're better off using the tibiotalar joint to describe the ankle joint. And make sure when you're describing the ankle joint, you're actually describing what we refer to as the ankle joint, because some people will point to the subtalar joint when that's not the ankle joint. It's in the ankle complex, but it's not the ankle joint. So as you can see here, here's our subtalar joint, and it actually presents towards the back. So a lot of times people will end up with heel pain here, and like I said before, it's like jumping out of a truck or hitting the ground too hard. They'll think it's plantar fasciitis, but their pain is more above the heel, but deep to the Achilles tendon. And so one way you can check this is you can grab the calcaneus and try to move it laterally relative to the rest of the foot. If there's no motion there, there's a good chance the subtalar joint has become fixated. It's one of those joints that gets jammed. I mean, you can think about the amount of force that goes into that. If you jump and land on your heel, or say you're a heel runner or something like that, it's pretty easy to get that joint stuck. In fact, it gets stuck much more than the true ankle joint does. So that's something that people don't work on when they're working ankle mobility. And keep in mind, the true ankle joint moves up and down like this, right? But the subtalar joint actually controls lateral movement. So where you're going to actually check it, it has some glide to it as well, but where you're going to create space is making sure that the calcaneus moves medial and lateral relative to the rest of the foot and the rest of the ankle. So we have our plantar flexors of the ankle complex. We have the gastrocnemius, the plantaris, the soleus, the tibialis posterior, the Achilles tendon, which is the common tendon of the gastrocnemius, plantaris, and soleus, the flexor hallucis longus, and the flexor digitorum. So as you can tell by the names there, the flexus hallucis longus does what? Flexes what? What is hallucis? You remember polysis?
So your
The hallux is the name for the great toe or the big toe. It has its own name. So the tendons that go here, the flexor hallucis longus and the flexor hallucis brevis, flex the great toe. So they make the big toe go downward. Okay. The longer one, as in the name, it attaches more distally, and then the brevis attaches more proximally. The flexor digitorum is a combination of all the rest of the digits. The 4 of them go as well. And there's 2 branches off of each part of the digitorum that allow secondary movement to each individual toe, aside from the great toe. Our dorsiflexors, we have the tibialis anterior, the extensor hallucis longus, which does what? Extends the great toe. Okay. The extensor digitorum and the peroneus tertius. So, by the way, the peroneus tertius is absent in about what percent of the population? Between 8 and 20. Yeah. So it's not really a major muscle group that we're going to acknowledge generally. We'll talk about the peroneus longus and brevis. Those 2 muscles basically work together to evert the foot. So let's talk a little bit about the motions, right? So dorsiflexion is straight up, right? Plantar flexion is down. Eversion moves the foot to the outside. Inversion moves the bottom of the foot to the inside. Everybody have those motions down? So evert, invert. So invert takes the inside part or the bottom of the foot to the inside. Evert goes to the outside. So the combination of some of those create 2 separate motions known as pronation and supination. So they are combined motions. So tightness in certain muscles that evert, invert, dorsiflex, or plantar flex the foot can give us the combined motions that look like pronation or supination. So the talocrural joint is a hinge joint and is the articulation of the tibia and the talus. It has 1 degree of freedom, so it only moves up and down. It doesn't have any ability to rotate any other direction. So when the rest of your foot moves inward in inversion or eversion, it's not happening at the ankle itself. It doesn't happen at the talocrural joint. It happens downstream from there at the subtalar joint and all the other joints that move around between the rest of your tarsal bones. Commonly restricted due to the retinaculum and by the muscle tension imbalances between the plantar and dorsiflexors, this causes restriction and dorsiflexion. So the most commonly lost motion in the foot is dorsiflexion. So people will be stuck in a plantar flex position. This comes from a combination of things: wearing heels, having gastrocnemius and posterior muscles that are much stronger and more developed than the anterior compartment. We talk about anatomically the gastrocs and the soleus and the plantaris, not the plantaris, are much greater in their circumference and diameter than the tibialis anterior. Part of that is an evolutionary trait because our eyes are only in the front of our head, not the back of our head, so we're designed to move forward in locomotion. We're not designed to go backwards. As a consequence of that, those muscles are bigger and they allow us to ambulate forward. Well, there's a biomechanical difference there where other places in your body you have a very symmetrical imbalance, right? Or balance, excuse me. Bicep and tricep are pretty close inside. The triceps is bigger than the biceps, but they're not far off. Hamstrings and quads are pretty close in girth and size. Erectors and rectus abdominis are pretty close in size. One of the greatest differentials you have is in the lower extremity, where the posterior compartment is much greater than the anterior compartment. So from a physics mechanical perspective, if you could imagine more force being constantly exerted from the posterior compartment, what that's going to do is hold you in a slightly plantar flex position. Just from walking around all the time, right? So as you develop those imbalances, that's going to hold you in a plantar flex position. That can also, so sometimes if we can't create dorsiflexion, what we're going to do is either swing the leg or we'll start to pronate more so that we can get motion so we don't trip on ourselves. Also, the retinacular tissue basically holds all the tendons together around the forefoot and the top of the foot. That tissue can also become rigid and tight over time. It does have fascial components to it. And what can happen there is it will also bind up those tendons to where you can't create dorsiflexion. So one of the greatest ways to restore dorsiflexion right off the bat is to clear the retinaculum, particularly in the front of the foot. So by whatever manual means you want to, whether it's scraping or pin and stretch or deep tissue, by clearing that area and also where the tibialis anterior ducts underneath there, that will allow you to create greater dorsiflexion. So if the tib anterior and the other dorsiflexors can't fire because they're being restricted and pinched at the retinaculum, guess what you're going to lose? Dorsiflexion. Make sense? So that's one of the easiest ways to do it. Also, by deactivating the posterior chain and then activating the anterior chain, that is also going to bring you to a greater position. I'm going to teach you guys an ankle mobility soon too that will also restore some of that motion. So there's a lot of things that you can do there, including strengthening the tib anterior and the extensor hallucis longus and brevis and those other ones, the extensor digitorum, that can help to dorsiflex that foot. So due to tibial torsion, which is the difference between the line of axis between the talocurl and subtalar joint, the foot rests in a slightly external position. The measured norm is between 10 and 15 degrees of tibial torsion. So everybody sits in some level of pronation off the bat. So anytime we create actual supination, there's a tipping going on there. So there's a slight differential when we look at the forefoot and the leg itself. It should actually overlay slightly that way, so it does move your foot slightly outward. So everybody has a little bit of slight external movement at the actual ankle itself. If it doesn't, it's because of some other pathology up or down the stream, or it could be due to rickets or some other bony pathology that puts you in a different position. But we're supposed to have a little bit of pronation. The subtalar joint. There's two joint capsules in the subtalar joint. The calcaneus contains a convex posterior aspect and a concave anterior aspect, allowing continued articulation of the talus and calcaneus. So what's concave? Does it cave in or does it stick out? Caves in. Caves in, right? Convex sticks out. So the joint can also become restricted and can contribute to abnormal foot joint biomechanics, and often does. So pronation and supination. Due to tibial torsion and the arch of the foot, the natural biomechanics of the foot favors slight pronation of the foot. So supination of the foot is made up of simultaneous movements in three directions or planes of motion, and they're kind of seen in the picture here. So we see inversion, adduction, so adduction, and plantar flexion. The combination of those three things puts you into supination. Okay? Pronation of the foot is going to be a combination of dorsiflexion, eversion, and abduction. Everybody see that? And again, it depends where your reference point is. Because we're slightly in a pronated position, that's why it's referred to as dorsiflexion of the foot, so dorsi is upward. I would actually argue mechanically it's probably the opposite. I would argue that the entire foot itself is held into a plantar flex position when you have pronation. Those two things tend to go hand in hand. Somebody who is a supinator oftentimes is stronger in their anterior compartment than somebody who is a pronator. So their peroneals and their lateral gastroc are going to be stronger and to pull them into that position. So those muscles will kind of make their toes point down slightly. Somebody who's a supinator will be in and out more. So I actually slightly disagree with the textbook description of those two things. However, if you were saying that the reference point is slightly lateral to midline, then yes, that does move upward relatively. And I think it's important to think about what these things do when they're in a closed chain or an open chain. We talk about that a lot in this class, right? Closed chain and open chain have completely different functions. So when your foot is on the ground, then what does it do? So I would argue a plantar flexor is somebody who's a pronator is going to plantar flex more so when their foot's on the ground. It's going to turn outward and downward some, and then their arch is going to cave in. A supinator is going to roll to the outside. Their weight's going to be on the outside of their foot. The arch is going to be higher, and there's going to get more engagement in the extensor hallucis longus and the tibialis anterior. But for test purposes, this is the information you need to know. This is how it's going to show up on your national boards. This is how the textbooks describe it. So pay attention to that slide for regurgitation for tests. But functionally, I would disagree with that. Okay. The only thing I disagree with, these two are correct. So pronation does have eversion of the transverse plane. It does have abduction in the sagittal plane. So they're just talking about the plane there, but I think that it goes downward and outward more so.
When you do it yourself, it kind of almost feels like that, because I was a little bit confused because... Yeah.
So do it yourself and you can feel the difference. So if you move into supination there, do you feel how that brings your foot upward a little more? And when you go to the outside and down, it's going to plantar flex. So what's the reference point? Yes, it does move slightly, up in the sagittal plane, but I disagree with the functionality of the premise. So, all right, so here's some disease states of the foot and ankle. So Sever's disease is a childhood apophysitis, which affects growing adolescence when the Achilles tendon produces bony changes at the attachment points. This is often referred to as growing pains in children. So like we talked about last class, the Severs from growing pains. Very clever, right? Very clever. So if you look here at the x-ray, you can see this kind of chewed out portion right here. So this line is the growth plate. So the metaphysis, and the reason why it's metaphysis is meta means change. So there's several components to it. We have the diaphysis, which is the long bone here, the epiphysis, which sits on top of it, and the metaphysis is going to be the part that's transitioning and creating new cortical bone as it grows. So as you take a cross-section view, we can look right here. We can see how this is pulled away. So the Achilles tendon, because it's, your tibia is growing, it's getting longer. So it's stretching the calf and stretching the Achilles tendon as it does so. Now, if you have somebody who's active as well, they're putting more torsion on that by running and jumping. Now we have that really soft bone in the heel that's trying to grow, and the apophysis can basically be pulled away from the bone itself there, and that causes a lot of pain. So we can't stretch these people, because if they stretch, what it does is pull the bone away more. Does that make sense? Anybody who's got growing pains, they should not be doing any static stretching. What we want to do is a bunch of inhibition. We want to turn that muscle off from the belly itself without putting any kind of shear forces on the attachment points. Like we talked about yanking on the doorknob with the rope, right? We don't want to keep yanking on it because the doorknob's getting damaged. What we want to do is cut the rope so there's not as much tension there. So these folks, I would have them rolling 4, 5, 6 times a day, having their parents roll their calves out. And when you do that, when you take that tension away, in these highly metabolically active kids with highly metabolically active bones, it'll resorb that tissue very well. If you don't get that taken care of during this phase, as their bones ossify, what they're going to get are bone spurs that are permanent for the rest of their lives. And you can see this on the ASIS, you can see this on the tibial tuberosity as well. If you have Osgood-Schlatter's disease that doesn't get treated and doesn't get healed, those people will have those big old bumps on their knees for the rest of their lives, which will contribute to arthritis and abnormal patellar positioning, because now it doesn't have the same attachment point as it should. Now it's a more shallow groove, so it doesn't have the right compression to hold the kneecap down. Does that make sense? So it's important that these things get treated before they ossify. This is a brand new concept, right? Nobody ever thinks like this. But I've seen so many of these cases get resolved, and they don't have to deal with these things into their adult lives. Like, just because it stops hurting doesn't mean it won't show up later on. So somebody that has an untreated Sever's disease is much more likely, again, to have plantar fasciitis and Achilles tendinopathy as they age, because the Achilles tendon doesn't attach where it should. It's going to be further posterior than it should be, and maybe further superiorly, so it doesn't have the right mechanical ability to pull that heel. So that means what? You won't plantar flex efficiently.
His treatment was, wearing New Balance shoes with that arch, literally, and the painkillers.
And I've seen people try to cast them or put them in boots too. I mean, it's ludicrous. You don't ever brace or cast or boot tendinopathies or apophysitis. Never. The only things you ever want to boot or cast are ligamentous issues and fractures, because you need those things to re-solidify. You need them to be more rigid. Does that make sense? These other things you don't want more rigid. You want more mobility to them. They need to be free. Anybody ever had a cast on before? No? I had one up to my hip.
Oh, God.
Brutal. But I couldn't bend my knee for like 2 weeks after I got it off, and that was 4 weeks worth, because my joint had become so stiff. Also, your muscles completely atrophy in that time. And then if you're imbalanced there, so now you have an imbalance that was created artificially, because your brain wants to move efficiently, now you may start to use that other leg much more than the original injured leg, and you may create an imbalance that you can never correct for the rest of your life. It definitely happened to me. As I started to run again, I would gallop because my left leg was weaker than my right leg. So instead of bringing up the strength in the one leg to get to where I was even and then building them equally, I built them up equally. So there was always a gap, and the gap actually grew because I was more comfortable with this side than this side. When you create those imbalances, you're going to have problems. And in my case, with that weaker left side, it gave me left SI joint issues, which I never had before that. So,
what age do adolescents, their bones ossify?
Generally between 16 and 20. Females quicker than males. So most of this pain will show up between 11 and 15, generally speaking. And females generally finish growing earlier than males, but not always, of course. So you're most likely to see this in young athletes that are just starting. And you can see them; they look like big puppy dogs. Their feet are bigger, and their shins are bigger, and they have this little baby face. It's kind of funny when they're about to hit a growth spurt. So yeah, this is when it becomes a really prime opportunity to teach these kids about self-myofascial release and how important it is in their life, just like washing their face and brushing their teeth. This should be part of their routine. And they'll notice the difference. They can feel the difference. So it's a good point to basically drive that point home, that this is how you take care of your muscles for the rest of your life. So plantar fasciitis, or plantar fasciitis, it's an enthesopathy, so that means an attachment point pathology, where the plantar aponeurosis attaches to the medial calcaneus. There's usually a thickening of the aponeurosis due to increased pressure from overactivity of the flexor digitorum, or from excessive pronation or supination, so pronation being the most prevalent, but you can certainly get this disease from both positions. So the dropped arch is the most common, but I certainly have seen supinated positions as well. You treat them a little different. the presentations are a little different as well. Like the supinated one is much more focal. The pronated one incorporates down the arch more. Originally, plantar fasciitis was believed to be an inflammatory condition of the plantar fascia, so that's why they would try to treat it with NSAIDs and corticosteroids. However, within the last decade, studies have observed microscopic anatomical changes indicating that the plantar fasciitis is actually due to a non-inflammatory structural breakdown of the plantar fascia rather than an inflammatory process. So it's the improper conversion of different types of collagen fibers and also some micro-tearing as well. So you're going to have a reorganization of the types of fibrinogen and collagen in there. So it doesn't have the same elasticity that it should because your body's trying to buttress against too much wear and tear and too much force. So pain is usually worst first step in the morning or after rest and eases as the motion has increased. So what you'll find is it's like stepping onto a piece of glass. First step, the more you move around, it gets better. But as soon as you stop moving again and then you get up again, it comes right back. So this is where we talk about connective tissue having physics components. When the tissue is warm, it's more malleable and it has the ability to contract and relax more. It's got some more suppleness to it. So while the tissue is physically warm while you've been moving around, or if you have heat on it, it feels better. It doesn't yank on the bony attachment as much. You also don't physically break down some of those crystalline structures. While it's cold, it's very rigid, it's very painful, it hurts a lot. So one of the easiest things somebody can do when they get out of bed in the morning is have like an electric warmer, even the hand warmers there, and then put it on their foot for 5 minutes before they take the first step. I also encourage people to not walk barefoot at home, so have slippers or something very soft ready for you. If you have wood floors and you have plantar fasciitis, you're going to have some problems first couple steps. And part of the problem, too, is that first step can actually damage the tissue, so it can cause it to break free even more or tear the fiber or the fibrinogen even more, and then it creates the cycle and it continues. So that first step is actually damaging to the tissue as well. It doesn't just cause pain, it actually damages and makes the process worse. So that's how you can kind of tell the difference between plantar fasciitis and peroneal tendinopathy or peroneal tendonitis. So I've had that one too. So I was running like a 5K. It was like a Thanksgiving one. Didn't get there early enough, so you're behind all these people like strollers, and I don't have the non-competitive thing in me. I was like, yeah, we'll just take it easy. I don't have that. I should know that by now, but I don't have that. So I take off, and I'm weaving in and out of all these dogs and like baby carts and stuff like that to get to the front because I'm trying to break 20 minutes. Started having a lot of pain on the side of my foot and it ended up going underneath. So the peroneus longus wraps all the way around the outside and it goes all the way to the great toe. So when somebody will complain of lateral foot pain and even on the bottom of their foot pain, you need to track that area with your fingertip all the way to the great toe. If they have pain under there too, it's a good chance that they have peroneal tendonitis. So what happens there is the shoe feels worse, and the more you walk, the worse it gets. So it's the opposite of plantar fasciitis. So the more you overuse that, the more it rubs against it, the more it yanks on it, and that hurts a lot. So you're good for the first few steps, and then like after like 10 or 15 steps, you can't even hardly walk anymore. So it responds very well to manual therapy. So does plantar fasciitis. So it responds really well to breaking down the tissue and inhibition of it. Oftentimes stretching is detrimental for plantar fasciitis too, and what you'll find is most enthesopathies, that's the case. So if something's yanking on the bone and causing pain as a result of that, stretching on it is kind of the last thing you want to do. So some good ideas here is make sure the talus is clear. So a stuck subtalar joint can lead to plantar fasciitis because there's no wiggle and there's no movement. A lot of times it's cured just from clearing the subtalar joint. You don't have to do the soft tissue work, but it does certainly help. But the combination of those two things, restoring dorsiflexion is also very helpful there, and then creating a better balance between the anterior and posterior compartments, so the things are going to help you a lot. Most of the time, they're going to be in that pronated position. You're going to find the more pronated foot is more susceptible to it. That being the case, as we go through our TheraX class next semester, we're going to work on TheraBand movement and stretching to basically counteract that and get us to a more similar alignment in a sagittal plane. So plantar fasciitis is often accompanied by concurrent bone spurs on the anterior heel. So we know with Wolff's Law, if that plantar aponeurosis yanks on the bone for long enough, what is your body going to do? It's going to lay down more bone. It's going to respond by trying to buttress that area by laying down more bone. All right, a bunion, Hallux valgus. So bunions are characterized by painful medial movement of the great toe with associated bony changes and inflammation of the joint due to stress on the joint. Overactivity of the extensor hallucis longus and adductor hallucis muscles is concurrent as well. The bursa and the sesamoid bones are often affected as well. This is almost always associated with an excessive pronation of the foot. You'll very rarely see a bunion with somebody who's a supinator. It can happen, but it's very rare. So that's a pretty nasty one, all right? So we can see what's happening there is that overpronation is causing the pressure on the anterior part of the great toe to push it that way. And as a mechanical force, if I'm pushing that way there, what's going to happen to the proximal part of the joint? It's going to stick out over here and become red and inflamed. Now there's a bursa sac there in the sesamoid area that can also become super inflamed as well. So these are reversible if you catch them early enough. So think about that. If there's a muscle now pulling my great toe that way too, what would I treat to get it back to here? This side, right? The adductor and the extensor. So if you clear that tissue out, that allows it to come back to here, and oftentimes you can cavitate the joint as well, which helps a ton. And it depends how much bone is deposited, right? You can see some bone resorption, just in the same way osteopenia and osteoporosis are possible. If you take pressure off of bones, bones can resorb some of the excess bone as well. But if they get to this point, you're probably not going to fix it. You can help with the pain. And it's tricky, right? This starts out as a cosmetic issue, but then when you surgically straighten that or fuse that joint, now you lose the ability to toe off. Think about what kind of mechanical disadvantages that can create. You see it all the time. So now what you're going to get is excessive motion of the dip, right? The distal interphalangeal joint, because the proximal one doesn't move at all. So their end of their finger or their toe will move like way too much. The ligaments will stretch out because they have nowhere else to create motion from. Also, because they can't toe off, what they're going to do is start circling the foot or creating some other sort of ambulatory imbalances, which will lead to knee issues and hip issues and things like that. So as much as we act like this isn't a big deal, if you don't catch these early on, they can certainly turn into things that can become life-altering. Yes, fusing the great toe will help the pain there, but eventually there's a consequence that comes home as well. Shin splints versus posterior tibial tendonitis. So anterior shin splints or true shin splints arise from stress from abnormal motion between the tibia and the fibula along with friction of the tibialis anterior. Posterior tibial tendonitis causes a medial stress reaction from excessive stress along the medial tibia. This is often accompanied by bony changes and thickening of the tendons. So what that posterior tibial tendon comes down to is around the inside of the shin. So if you guys reach under your shin right now and feel the posterior aspect of it, you should probably find some bumps. And they're pretty sore. Got any? We all pretty much got them. So that's the way you treat that area too. So when somebody's having pain on the inside part of it, and this is going to be mostly runners, all right, that's how you treat that area. So you've got to clear the tendon and the synovium so it doesn't yank on the bone too much. And so these are the two areas we're going to see. Common anterior side of anterior shin splints is going to be the medial aspect of the shin there from the tibialis anterior yanking too hard on it. And then also we have the posterior shin splints as well. This is much more common here. The anterior one is the true one, and we think that there may be some torsion also between the in the aponeurosis between the tibia and fibula. So it's important to clarify those two things. So overpronation, oversupination, both of those things can contribute to posterior tibial tendonitis. We'll talk more about it in the sports medicine class about what your interventions are going to be, what the timeline looks like, and how you differentiate between the posterior tibial tendonitis, medial stress reactions, and medial stress fractures, which are all different pathological processes that all require different interventions. Also different modalities of imaging if you're going to clarify one versus another because they have different metabolic tendencies. So looking at the rest of the foot, we have Mortons Neuroma versus a stress fracture. So these can be midfoot pains. So a Mortons Neuroma, so as you can imagine what the name says, neuroma would be what? An oma is a what? We'll just use the term tumor for this purposes. So you'd have like a tumor or growth of a nerve, which is kind of true. It can kind of turn into that, but more than anything, it's a pinching of that nerve itself. So between the metatarsals, there you're going to have rubbing and friction there. It's going to cause a little bit of numbness, particularly between the third and the fourth toes. So what you're going to see here is if you compress the metatarsals together, that will elicit the pain and a little bit of electric response. So one of the best ways to use this is using something like an activator or some other manual tool because you need to create some space between those metatarsals. What you cannot do is try to create space here because like we talked about before, if you have two objects like this and I'm getting pinched here, if I try to move these two apart here, what am I going to do here? I'm pinching it more. So people will try to pull these things apart or put a spacer in there, but what they're actually doing is causing more inflammation and more pinching downstream. So what we have to do is create the space between the metatarsals themselves, otherwise you're not going to get a hold of this. If that doesn't work, they could always get a corticosteroid injection, or sometimes they end up removing that neuroma out of there, which can be a problem because when they do that, you'll never get the sensation back in that part of the foot. Stress fractures of the metatarsal bone are fairly common. This often happens in people that have taken a break from some sort of activity that they used to do. So we'll see this in women that were runners. They took the time off when they were pregnant, and they figured they could just run back out there and get back to running 10 and 15Ks again. So what they can't do, they didn't realize, is that we have Wolff's Law. When you don't stress your bones for a long period of time, your body takes that calcium back, and so those bones are weaker. So they think they have the ability to do that exercise, but they don't. That's when I'm not as good as I once was, but I'm as good once as I ever was. So this is why you always have to gradually work on any kind of form of activity, is your body has to have time to adapt. It's not just your nervous system or your muscular system, but it's also your bones and your ligaments. They have to have time to adapt to the stresses as well. That's why when people go out and want to play, backyard football on Thanksgiving, they end up tearing all kinds of things. Even though their brain knows how to do the activity, it's like riding a bike, their ligaments and bones aren't ready for that kind of adaptive forces, even if their muscles are. Okay, so if you don't use it, you lose it, right? So Achilles tendonitis, irritation of the Achilles tendon from abnormal stress or mechanics. Typically, there's a thinning in the belly of the tendon and thickening at the attachment point on the heel. Oftentimes, bony changes can occur and can cause what is called a Haglund deformity. Fraying of this tendon can place a person at increased risk of a full rupture of Achilles tendon. And there's a test for that. It's called Thompson's test when you pinch the calf. Generally speaking, if they have a torn Achilles tendon, you don't need Thompson's test. Okay, it's pretty obvious. It's rolled up. It sounds like a gunshot. The person will feel like somebody hit them or kicked them in the back of the leg. It actually won't hurt at first. They'll go down and they'll feel like somebody hit them with a broom on the back of the leg. And then it'll start to set in and they'll realize what's going on. All right, another big component, this is really important for you guys to learn, just like the hand, is the innervation of the foot and ankle. So as you can see here by this dermatome chart, these are generalities. Here's the cutaneous nerve innervation of the foot. Here are your dermatomes. So L5 generally is going to cover the diagonal portion across the foot, going to the big toe. S1 is going to be the lateral couple toes, also the heel as well. So in L4 is going to be slightly more medial to that. So when we're looking there, when we're trying to correlate that, so the reason why we talk about this is differentiating between neuropathy and radiculopathy. When somebody has radiculopathy, that means the nerve root is being impinged upon or infringed upon. So that would be a disc herniation at L4, L5, L5, S1, or some area like that. When we truly have those symptoms, what you're going to see is a very pure representation that looks like this. So if you truly have an L5, S1 issue that's pinching a nerve, what you're going to see is this representation here. L5, S1 gives us which one of these? You guys never learned this, right? Okay. It's going to give you S1. So you don't have any other nerve roots like that. So the only area that differentiates from that is the cervical spine. So you have 8 nerve roots in the C spine, so you're going to have a C8 nerve root. That's between C7 and T1. Everywhere from there down, you're going to describe it as the level below. So if I'm talking about S1 nerve root, it's going to be between L5 and S1. When I'm above C7, that's not the case. So that's the exception. So if I'm looking at L5, I'm talking about the level between L4 and L5. So a herniation between L4 and L5 will give me this L5 presentation. I'll have numbness in the big toe, and then also your myotomes and your reflexes will add up to that. So it's actually like math. So if you have a dermatome, you should also probably have a weakened myotome. And we're going to do a dance for that coming up where I can teach you guys the common myotomes so you can check muscular strength in the upper extremity and lower extremity to give you a correlation with the lower back. And oftentimes they may not even have back pain. So back pain is not really a symptom of a disc herniation. The true symptoms are these downstream nerve referrals. So when somebody has a burning pain or a numbness or with some other paresthesia that travels these pathways, that's going to make us look upstream. Oftentimes you can positionally change them, and that will also affect these things as well. If you get to the point where you have this kind of an issue and there's no position that ever makes it feel better, they may be looking at a surgical intervention. That's when you'll know clinically that you can't really help that much. I still would try to treat them once or so just to try it. I mean, I've had many cases where I thought for sure this person's going to need surgery, and I've treated them and gotten rid of them. So it's definitely worth your try, but you have to keep it in the back of your mind. If they can never find a position that gets them out of the sensation, ever, like sitting forward, leaning to the side, there's less likelihood that you have the tools necessary to get in there and actually make a change. There may be so little space in the foramina there that there's nothing they can do other than surgery. And it's, a laminectomy or discectomy is worth doing if you're losing nerves in your feet. As much as everybody's against spinal surgery, when you need it, you need it. Just like any intervention, right? It's just finding the appropriate piece people to do the interventions to. So looking at some of our other peripheral nerves here. So here's where it can be tricky, and this is where you guys are going to have to get really good at detective work. So using a pinwheel, for example, to basically define the boundaries. These are pretty good. Everybody changes a little bit. There's not a 100% correlation, but they're pretty darn good, especially when you correlate it with your myotomes and your reflexes. Now when we're looking at this is kind of like in the upper arm, the median nerve, the ulnar nerve. So you have the saphenous nerve, the superficial fibular nerve, the deep fibular nerve, and the sural nerve. These nerves are formed after the sacral plexus. So if these are showing up, they're being pinched in the leg, not upstream, which can happen. Fibular head positioning, fascial restrictions. I've definitely seen a few patients in the past with fibular nerve entrapments at their peroneal head, at the top of the foot, that everybody diagnosed as sciatica, but they didn't have any issues there. So we treated those areas, and their foot came back to life. Healed. But nobody problem solves, right? So how do we know our reality, right? We test our theories. So if I think that I might have a fibular nerve entrapment, I should probably treat it like that. And if it gets better, what does that tell me? If it gets better for treating the fibular nerve, it's not a radiculopathy. It's a peripheral neuropathy. So some of the entrapment points for the superficial and fibular nerve are going to be around the posterior aspect of the fibular head, about halfway down the shin, and then also on the top of the ankle. So you can clear those out with manual work, and they will work pretty well if that's what it is. And you will see kind of the same patch sensation, so the deep fibular nerve will be more numb than the superficial, just because it's a pure patch for the actual peroneal nerve itself. Okay, looking right here, number 6, this is the calcaneal branch of the tibial nerve. With somebody with true sciatica, like their actual sciatic nerve is being impinged either at the piriformis or downstream, one of the areas that they're really going to have here is number 6, the heel itself. That's going to be the deadest spot. Now, when you look right here, see S1 also covers the heel. So how would I differentiate this from this? I would run the pinwheel up here at 5 and 7, right? And if they felt that, then I would be more convinced that it's this and not this. If the whole thing was numb, now I'm going to be more convinced that it's this and not this. Combining those with your imaging, combining those with your muscle strength tests, that's going to give you your triangulation so you understand reality, which is using what method again? The scientific method. Because guess what? Your exam and your problem-solving strategies are much more efficient and effective than imaging. Imaging is lazy. It is a nice piece of information, particularly when you're dealing with space-occupying lesions like cancer and tumors and things like that, but it's really not that great for clinical entities. So many people will show up with bulging discs at L4, L5, L5, S1 that don't have any kind of peripheral issues. They just have back pain. So odds are they have some muscular issue in the back, but they also just happen to have an L4, L5, or L5, S1 disc bulge, which we know between 85 and 95% of people that have never had back pain have disc bulges and disc herniations. Also, there's been many studies done that show that there's no correlation between the prognosis of back pain and disc herniations and disc bulges. Some people's pain gets worse, and when you reimage them, their discs are actually healed, and vice versa. Some people's discs have deteriorated as sequestrations, but they don't have any pain anymore. So it's not a telling entity. Okay. Also, the way we do MRIs is pathognomonic as well. I had a patient the other day. She's a PA. She had a pure L5 S1 presentation. No position changed it. Her muscle weakness was what I expected to see. But they said, my MRI is not that bad, all things considered. And I said, does your pain get much worse when you stand up than when you lie down? She said, yes, it does. Well, I said, think about this. Why do they do your MRI when you're laying down then? That doesn't really make sense, right? If the weight of your body pushes down on that disc and then the disc material pushes posterior onto the nerve while you're standing, it seems like it would be a lot better idea to take that MRI standing than lying down. Because they're like, oh, your back's not that bad considering your symptoms. Your symptoms are telling you actually what's going on there. That image is not really that good because you don't have as much symptoms when you're laying down, which is where you took the image, which is dumb. Come on.
Do they do MRIs?
Yeah, they can. Somebody has to order it. It's your insurance will probably fight you on it because they don't want to do anything you're supposed to do.
Yeah.
They don't want to trust physicians' input, right? They just want to do the algorithm. I was having this conversation with somebody the other day, and they were like, chiropractic, naturopathic, blah, 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 blah. Like, how come you can get results but other people can't? And like I said this, listen, I'm probably on the autistic spectrum at some point, but here's the thing. If you stick somebody with a 140 plus IQ with a certain set of skills and you let them play with it for 8 or 9 years, they're probably going to figure out ways to be good at stuff, right? It doesn't matter what profession they're in. So what we need to do now is when you start to develop these sets of skills, we have to pass them and share them with each other. Because not every single provider is going to have that kind of critical thinking ability. They have to have it taught to them. They can expand on it and grow on it, but unfortunately in some of these professions, I don't feel like they ever had these kind of people that were the lights, the beacons that use science and problem solving to come up with these kind of things, to develop new tricks. Like, listen, I've only got a stick and I've got to make a fire. Well, all the idiots are just going to bang the sticks together, but if you can figure out how to make them work together to create fire, and then pass that on, that's how we transfer intellectual ability to each other and grow as a profession. And because these professions are so fractured and isolated, I don't feel like that's happened. I feel like they learned a bunch of minutia in school that was not clinically useful, and then they don't share that with each other. And that's why so many of them suck. They do. Like, people are always asking me, they're like, hey, can you refer me to a chiropractor? I'm like, I'm not going to refer you to somebody I've never been treated by because I don't know their philosophy. I don't know the way they think. I don't know their intellectual capacity to have this kind of a critical thinking conversation with you. And it's not just chiropractors. I wouldn't send you to a dentist I've never been to either. I don't know why that's complicated for people. Like, you're going to have to do some research on your own. You're going to have to discuss them and make sure that the things that they're talking about, their ideas, make sense to you in your head. And your clinic may not be a fit for everybody, and that may also be the case for me. If I'm discussing ideas of fascia and connective tissues with somebody, it may not jive with them. It may not make sense for them, so they may not be a good candidate for our treatment. Like, if you're not willing to do the work that we're asking of you, then the outcomes are probably not going to be that great. So we're just wasting your time and money as well, right? But yeah, I think that, like, as we discover new things, and we're only just scratching the surface, but once we master the anatomy and physiology, we know what we actually do. Like, you can be so creative with this stuff. This is the longest running science experiment ever. I was telling this UFC fighter Tim Means today, like, we have a couple people, their ulnar nerves, they've had so much damage there with their elbows, their ulnar nerve doesn't sit in the cubital tunnel anymore. It sits on the outside edge, so it's on the medial epicondyle. So when they touch it to things, it shoots down to the pinky. You have that? And I haven't figured out a way to get that back in there non-surgically. That doesn't mean it can't happen. It just means that we've got to figure it out. And once we do, then we need to tell other people about how to do that, right? Just the same way I'm teaching guys how to treat plantar fasciitis and all these other issues that I basically figured out on my own over time. Like, nobody ever taught me how to do those, and most people suck at treating those areas. Otherwise, why wouldn't all the doctors be fixing them? Because they don't know. They're constrained by their own boxed-in thought process. This is just what I do because the textbook says. Okay, we're problem solvers. We can grow beyond that, right? We're better than that. And if something doesn't work, then we either need to throw it away or we need to figure out why it didn't work so we don't apply it to the wrong patient population, period. Just like I talked about previously, like, we don't manipulate old people. Why? Because it doesn't make sense, and we've seen adverse reactions from it in the past. Why don't we stretch adolescents? Because it doesn't make sense pathophysiologically, and we've seen bad outcomes from it in the past. Like, you have to acknowledge what you actually see in clinical practice and then build on it and expand upon that. For me, with my weird robot brain, I remember all of it. For you, you guys need to take notes. Some of you may remember more things than others, but, what I found with my providers is, like, when they take notes, they're not going to remember all these arbitrary random things like I do. So I am blessed in that sense. It can be a detriment in my life, and it totally is in a lot of other areas, especially interpersonal, things like that. Everything has a gift and a curse to it, right? But, like, for them, when you find a new discovery, write that stuff down because you may not see that case again for 20,000 more cases, and you'll forget about it. So then the next time you see something like that, you go, oh, I remember I fixed it doing something, but I can't remember how. So when you come up with a cool new discovery, make sure to spend some time, take down, write through what you thought was going on, what the process was, what your theories are, and then you can test that the next time you see something out, And you may just have gotten lucky and treated it for some other reason. You may have thought you had a breakthrough. Once you tested it on a few people, maybe they got better for some other reason. Like, for example, the reason why cortisone shots work on plantar fasciitis sometimes, in my opinion, is sometimes every once in a while they hit the attachment point where it's painful and they numb it. So the person can walk normally for a period of time, which stretches the plantar fasciitis out without the inflammation going on. So they basically get that opened up and moving, and that's why it works. Not because they blunted inflammation. They just got lucky and numbed it. That's why most of the time they don't work. Because we know it's not inflammation, right? So why would a corticosteroid help that? Pathophysiologically, it shouldn't, right? Other than maybe that it has a numbing effect. So if it works, we need to come up with some theories why, and then we need to try to test that in the real world. Is that a double-blind, placebo-controlled RCT trial? No, it's not. But for the purposes of healing people, we don't always have to have that. The reason why we want to have these logical thought processes as clinicians is so that we can apply the best possible treatment to the right patient and get those things matched up. Based on anatomy and physiology, which I would argue is evidence. I think it's about the best we have. It's kind of the Rosetta Stone, right? Everybody know what the Rosetta Stone is? It allows you to, read all these other texts. It translates between all these other things. That's the common language between all medical professionals. That's how you should be thinking all the time, too. What do these muscles do? What's the physiology? What's going on with the sarcomere? What's going on with the tendons? What's the Golgi tendon reflex doing here? If something works, now we don't just go, I don't know why, or come up with some bunk reason. Then we come back to the basics. And when we talk about explaining things, right, we need to break it down to the smallest possible common denominator. Like if you're talking chemistry, you want to break it down as simplistic as possible to the smallest pieces to communicate the specificity and the detail of it. You don't want to talk in generalities to each other or to yourself. Now, to the patient, though, they don't really care about that. They actually want the generalities. So you'll have to develop this communication device to go back and forth from the general to the specific. That's why I get really far behind when I'm treating healthcare providers, because I get super excited that they know what I'm talking about. Because I'm not saying, oh, this is pulling on this or this is pulling on this. I'll explain it to them in the terms that they understand, and it's always cool because like, oh, that makes perfect sense. Which is nice reaffirmation for me and my thought processes, right? Like it's good. All right. Everybody had a good handle on the physics lecture? Okay. We're doing better this course than I did last time. We've gotten through a lot more of the lectures, actually, surprisingly. I don't know what I was doing last year. So, we didn't actually get a chance to go through a couple of these. We didn't actually get to do the corrective exercise lecture last year and a couple of the other ones. How many weeks do we have till the final? Anybody know?
4.
Oh, we got lots of time. Got so much time. All the time. So I already sent you guys those 2 lectures. So you have the physics one. You're going to have the foot ankle lecture too. So going back to what we were talking about pronation. So the calcaneus is going to sit laterally in somebody who's pronated. So the talus is relatively medial. That'll cause that indention, the dipping forward, right? That'll cause more of that tension on the great toe. Okay, so the calcaneus is one of the greatest predictors positionally relative to the talus of supination pronation. If the calcaneus is medial relative to the talus, that's going to tip the foot to the outside and increase the height of the arch. So there's 2 perspectives you can look at it, the talus relative to the tibia and the calcaneus relative to the talus. Because we know there's no degree of freedom laterally of the talus to the tibia, really any positional work there is going to be at the talus and the calcaneus. So if you want to correct that pronation, what you need to do is to get the tissue that pulls the calcaneus laterally to not do so particularly the peroneals and some of the fascia there, and then you may need to move it relatively medial compared to the talus. By doing that, you're going to put them in a more neutral position, or vice versa. If somebody's supinating too much, you need to move the calcaneus laterally relative to the talus. You need to get those muscles that are pulling you to the inside to calm down. Then you need to strengthen the ones on the other side to balance it, to hold it there. So if somebody's not holding treatment right, what does that tell us generally? They're not doing enough strengthening. If somebody feels great for a day or two, right, that means we were inhibiting things too much. We're loosening things too much. So that means that what you're doing is working, but you're not able to maintain any kind of change because they're not doing any strengthening. So a lot of times you'll have these people, they come in and they're rounded like this, and then you work on their neck, which is already inhibited. They feel great for a day or two, but what you really just did is you turn off the muscles that were kind of holding them together, which felt great for a little while, but now they don't have the musculature to help hold them back the rest of the time. The middle traps, the rhomboids, the rear delts, those muscles, they need to hold them in that position. So they'll fall apart in a day and a half, and they'll go right back to where they were with cognitive issues, sensitivity to light, dizziness, headaches. So when you see that kind of a presentation, what that tells you is mostly is we need to add more strengthening. They're not able to hold those positions. Okay? What do you mean 502 web server received an invalid response? Get out of here. All right, so let's talk a little bit about assessment. So one of my favorite tools, as far as like generalities, if you want to help to look to find what muscles are overactive, underactive, is the NASM overhead squat assessment. The NASM OHS is the quickest, easiest way to perform at the start of a sport season. Information obtained can be used to tailor prehabilitation programs specifically to the needs of each individual athlete. And there's a little word about prevention. So the OHS assesses total body structural alignment, dynamic flexibility, and neuromuscular control from a bilateral standing posture. Squatting requires optimal motion in the ankles, knees, and hips. If you lack motion in one of those, you're going to have imbalances, and you're going to create motion at places you probably don't want it. Having the arms elevated overhead, what that does, it stresses the musculature surrounding the shoulder complex. It increases the demand placed upon the core stabilizing muscles, which can also lead to imbalances, rotations, or arms that fall forward or back. The rationale behind the overhead squat assessment: to perform the OHS correctly without compensation and structural alignment, one must demonstrate optimal and bilaterally symmetrical dynamic range of motion at each joint, so the length-tension relationships must be correct, optimal force-couple relationships or proper recruitment strategies. So practicality: once the compensations are found, we'll be able to tell probable overactive muscles. So then we want to inhibit and lengthen those ones as well. Flexibility exercises will be used, including self-myofascial release, static stretching, and neuromuscular stretching, or PNF. Probable underactive muscles, so we want to activate or integrate those things, and that's going to be where we strengthen those exercises. So positional isometrics, isolation strengthening, also integrated dynamic movement is very important. You need to be able to move and be strong in those movements as well. We are designed to move. So we look at this little pattern here. We have these four components that work together. So we have inhibition, lengthening, activation, and integration. So these are the four components to that NASM assessment. So you always want to inhibit first, then you're going to lengthen, aka stretch, then we want to strengthen, then we want to integrate. So we're going to isolate, strengthen as the third component. You will see this on a lot of tests next semester as well. So kinetic chain checkpoints. We're going to look at the foot and ankle. We're going to look at the knee. We're going to look at the lumbopelvic hip complex. It's not compels. Sorry about my spelling. The shoulder, the cervical spine as well, so the upper body. The overhead squat assessment, you're going to have an anterior, a lateral, and a posterior component to it. The setup, you're going to have the feet straight forward, shoulder width apart. Hands are going to be raised over their heads as shown. The procedures, you're going to perform a series of squats 5 times per view. Squat to the depth of an average chair height. So an anterior view, your kinematic checkpoints, you're going to look at the feet, you're going to look at the ankles. The feet should be straight ahead. The second metatarsal of each foot should be parallel to one another. So if we don't have that, we need to put them in that position. The reason why they may not be there is they may have some sort of kinematic deficiency that puts them there, or some sort of injury as well, right? It may not be a deficiency, it could be an injury, it could be an old injury as well. It could be previous surgeries. So the knees, do the knees move inward or do they move outward? So that's important to check that as well. So the anterior view, so if the feet turn outwards, we're going to look at the checkpoint. The feet turn out in that squat, right? So the probable overactive muscles, we're going to think, and this makes sense, the soleus, the lateral gastrocs, the biceps femoris, okay, the tensor fasciae lata, so those are all our lateral musculature. Does that make sense? So it's going to externally rotate your tibia and your femur, so the muscles that would do that are going to be the lateral muscles. TFL is an external rotator of the hip. Bicep femoris, so you have your two muscles on the inside, semimembranosus and tendinosus. On the outside, your two muscles are the biceps femoris short head and biceps femoris long head. Okay, those are going to, because we talked about like the position right before, if those two engage more than the medial hamstring, it's going to turn the femur slightly outward. Just like you're going to get more contraction of those muscles when your femur is already slightly outward. Remember last week we talked about those kinematic positions? So if my femurs are turned outward and I contract my hamstrings, my lateral hamstrings are going to get more engagement. So I'm going to have more activation through my bicep femoris than I will in my semimembranosus and tendinosus. Same thing with the lateral gastroc versus the medial gastroc. Everybody following here? We're drinking out of the fire hose again? Just keep swallowing. All right, so probable underactive muscles in this case. We have medial gastroc, so this is going to make a lot of sense. So the ones that the opposites are going to be weak. Medial gastroc, medial hamstring, gluteus, max and med. Okay, gracilis and popliteus. One could argue that glute max might not be there because the glute max is an external rotator there. But what you're going to see here is a combination. If that's turning out, you're going to see a pelvic tucking. But the glute max is also an extensor, so we shouldn't see those two motions combined. I wouldn't worry about it too much. Unless you see a drastic change out there and they also complain about having some glute max tightness or SI joint issues, then it might be the glute max primarily. So one way you could check that, right, is have them do an overhead squat assessment, have them lacrosse ball their glute max, check it again. So you're going to use this as a tool to help you assess what's tight and what isn't on people. Your interventions are going to tell you if you're right or wrong. So if you suspect that they're having a problem because their IT band and their glute max are tight, well, your intervention is going to be to roll it out or to treat it with manual work, right? And then recheck it again. One of the big things I like to do in the office is to have them do self-myofascial first to basically treat all those muscles anyway to give me a frame of reference and an idea where I'm going to treat more manually. Then I'm going to get more specific with my hands. Then what I want to do is reorganize their self-homework to basically do the exact same things that I did to them on their own. So once they felt the things that I did to them that made them feel better, the goal of the corrective exercise at home is to basically simulate those trigger points or soft tissue areas where I work with my hands or my elbow or whatever, to where they can do the exact same thing with a lacrosse ball, a foam roller, a PVC pipe, or a stick, or whatever. Okay, if the knees move inward, the probable overactive muscles, we're looking at adductor complex. Make sense? So adductor magnus, gracilis. You can have the biceps femoris short head. Okay, the TFL, the lateral gastroc, and the vastus lateralis. So now that we're not talking about rotation, we're talking about inward movement of the knee. Everybody follow there? Any problems with that? No? You're going to get this chart so you can keep rereading it and process it in your head. So underactive muscles, medial hamstring, medial gastroc, vastus medialis, or VMO. If the knee moves outward, probable overactive muscles, piriformis, bicep femoris, TFL. So interesting, the TFL is going to be overactive in both of these, right? Okay. Gluteus medius and gluteus minimus, if the knee moves outward. Okay. And that's, again, in a non-pathological state. So this is a functional lesion, right? So if I'm lacking part of my meniscus, might my knee move outward as well? So that's not due to a muscle, that's due to a mechanical issue. Also, poor ankle mechanics could certainly do that as well, to where it'll appear that this is the case. So the way that we rule that out is if we think that might be the case, we'll treat all these glute muscles. If it doesn't change, then we know it's not coming from there. We'll move on to the next area. So this can become algorithmic for you guys in a way, to where you at least have some sort of frame to work from, even though we're not being protocol-based, right? All right, probable underactive muscles, the adductor complex, the medial hamstring, and the glute max. From our lateral view, we have two main checkpoints from the lumbopelvic hip complex. Excessive forward lean, back round, and back arches are kind of what we're looking for. From the upper body, what we're checking to see if the arms fall forward. So see our lateral view, this is going to be an excessive forward lean. So that's not what we want on the right side. This is not bad, but at least it's symmetrical, right? So at least we have the shin and the back kind of lining up correctly. In this case, we have the shin lined here, and then this whole line through the upper body is off kilter. We want parallelity. We want parallel between those two areas. All right, so for our lateral view, so the upper body, we're checking the compensations if the arms fall forward. So if my arms fall forward in that overhead squat, the probable overactive muscles are going to be the latissimus dorsi, pectoralis major minor, and the coracobrachialis. That one makes a lot more easy sense, right? All right, probably underactive muscles, mid-lower trap, the rhomboid, the posterior deltoid, and the rotator cuff. Lumbopelvic hip complex. If I have excessive forward lean, the probable overactive muscles, you may see soleus, gastrocnemius, hip flexor complex. Possible underactive muscles, we may have anterior tibialis, gluteus maximus, and erector spinae. If the low back arches, we have a hip flexor complex that's overactive, an erector spinae that's overactive, and a latissimus dorsi that's overactive. Why latissimus dorsi? Because it attaches down the entire lateral posterior aspect of the T-spine to the L-spine into the lumbopelvic area through the thoracolumbar fascia. Cross crawl, right? Probable underactive muscles, we have glute max and intrinsic core stabilizers. So if my low back rounds, probable overactive muscles, hamstrings, adductor magnus, rectus abdominis, external obliques. Probable underactive muscles, glute max, erector spinae, intrinsic core stabilizers. So when evaluating what these muscles do, think of them as pulling antagonistically or agonistically. If one is tighter than its antagonist, it's going to create a bony positional change. So we're going to compare these two to each other. So my arms fall forward, my pecs and my lats are tighter and stronger than my rhomboids, my posterior delts, my rotator cuff. If these ones were stronger, my arms would go flying back. So when you're looking at these relationships between these two, that's what we're looking at. Okay? All right, posterior view. Our checkpoints are the feet. So if they flatten or the heels rise, that could be an issue. Also, the lumbopelvic hip complex, we have an asymmetrical weight shift. Like if you shift to the right or the left, that could tell us there's either an imbalance or maybe there's an injury or some sort of biomechanical defect. So the posterior view, our checkpoint's going to be the feet. So if the compensation is flattening of the feet, right, or pronation, we're going to see is probable overactive muscles. You're going to have the peroneal complex, so peroneus tertius, longus, and brevis. The toe extensor complex, so we talked about the hallucis longus and brevis, the extensors, right? The lateral gastrocnemius, the bicep femoris, and the TFL. The probable underactive muscles are the posterior